Thank you. Thank you very much for inviting me to speak today about our initiative, our registry, not really European registry, but international registry in Alpha-1. These are my conflicts of interest. Well, the story started here. It started with a statement of the ERS about management of Alpha-1, a pulmonary disease in Alpha-1, basically. And one of the statements, which is obvious, and we all agree on that, is that the systematic collection of data concerning clinical characteristics and natural history of patients with a deficiency in registries will enhance the knowledge about the evolution of this disease and its optimal management. And as you are aware, basically in Europe, we had an international registry which was very successful in collecting baseline data from a significant number of patients. But in fact, it was not so successful in collecting follow-up data. And therefore, we decided that in the context of the ERS and under the endorsement of the ERS, we should try to develop a new prospective follow-up registry. And the ERS has these CRCs, the clinical research collaboration, which are aimed to put together a group of researchers around Europe, but also beyond Europe, interested in one particular respiratory disease. And therefore, we apply for a CRC, and the ERS endorse our clinical research collaboration, the EARCO, the European Alpha-1 Research Collaboration, in collaboration with the patients, with the European Lung Foundation, and basically with some industry partners that provided funding. And the main objective or the main research project of EARCO was the EARCO registry, but not the only one. We want the registry to be the backbone, the scaffolding of a series of research projects that initially they were 3, but now, as you will see, there are more research projects ongoing or in plan. So regarding the registry, which is the topic for today, it was launched in February 2020, just a couple of weeks before the pandemic. The aim was to recruit 3,000 patients in the first 3 years, which we lost almost more than 1 year due again to the pandemic. To gather information for centers initially across Europe, but as you will see, we extended beyond Europe. To integrate data with pre-existing national registries, facilitate longitudinal studies, collaboration with other registries, and to attract new and young researchers in the field of Alpha-1. We published the protocol, and these were the initial countries that were associated with the EARCO registry and the EARCO CRC initiative. The protocol, I don't think has anything in particular, so these are the usual tests, diagnostics, and follow-up tests that should be conducted in patients with the disease. We also included some liver measurements for patients who have them. And basically, the main point is that we include severe deficiency, that they do not have any normal M allele. We also accept heterozygous, but SC or severely deficient alleles. This is a summary of the data collected. So we have sociodemographic, clinical, Alpha-1 related, complementary tests, treatment, and also some patient-reported outcomes. There was a 1 yearly follow-up, and there is a quality control of the data included. So this is the recruitment. You can see here, this is the pandemic period, and this is the post-pandemic. And only after this summer, the slope got steeper, and we increased the speed of recruitment significantly. When I produced this slide last week, there were 531. Now, today, we have 560 something patients included. And these belong to these countries. There are 49 sites in, I think it's 20-something countries, including, as you can see, Colombia. So it's also the first country in Latin America that has joined the registry. And Spain is the one that has more centers, but also UK has 5 center actives. And there are still some centers that are they are in the process of signing contracts and getting ready to start. These are the sites that are the most recruiting sites. You can see from different countries, including Sweden, the UK, Spain, Portugal, and the Czech Republic. These are the recruitment by countries. Again, Spain, the UK, Portugal, Italy, and the Czech Republic are the main countries in the registry so far. Well, as I said, EARCO is more than a registry. We also develop a survey to guide our research for the future. And it was recently published also research priorities, both by research specialists, but also by patients and caregivers. I will not go into detail. They are described in the publication. I don't have time for that, but just to show you that we have a research agenda in the EARCO. Those who are interested can go to our website. There is complete information about all these aspects in our website. All the members of the EARCO are there, and also the publications generated so far. Information for patients regarding the associations, not only in Europe, but globally, and also the research projects. As I presented just the EARCO registry and the research priorities, but there are currently 8 other research projects already started or in planning phase for the near future. And finally, just to show you our activities, these are the 3 abstracts presented in the last ERS Congress a few weeks ago. One on COVID-19 and Alpha-1, the other one on the harmonization of labs, diagnostic labs across Europe, and the other one regarding the baseline characteristics of the first 500 patients included in EARCO. And with this, I finish, and I will be happy to comment if you have any questions. So I think I pass the word to Jeanine.
Yeah. Okay, great. So I just wanted to just briefly talk about the Foundation's research registry as obviously the main focus is the EARCO for the registry that's global, but we're going to I just want to talk about what we've done at the Foundation. Initially, our registry started at NIH when work was being done on augmentation therapy, and then got transferred to the University of Miami after the NIH closed the registry, and subsequently to the Medical University of South Carolina. But in about several years ago, there were several initiatives to bring registries back into the Foundation, and tools were developed through NIH and through other methods so that foundations could have their own registry. And in this way, we can pool all the patients together, all the data together to have a really robust natural history study or biomarker study or whatever is needed so that we can move forward towards the cure. So what we did at the Foundation was in 2018, the decision was made to bring the registry back in-house. It was restructured. It's very similar to what was at MUSC, similar questionnaires, a little bit expanded, but not that much different. We got an IT person who built the database using REDCap software. This is essentially free software, fairly free software, or low price for a modest yearly registration. And the environment that we built with our IT people was secure online environment, which is a similar service that's used by the Pentagon. So the registry works such that the patients can go into an registry portal that's on our website, and then fill out the data that goes into a REDCap database. And eventually, right now we are here, but we're building what's called an I2V2 portion, which can pull de-identified data from REDCap that allows us to do further analysis and further studies without patient identification. All of our Foundation staff underwent good clinical practice, health insurance portability, and HIPAA, the HIPAA compliance, which is the United States requirement for you to work with patients. And therefore, we are able to submit our RVs and keep our registry under HIPAA compliance. So let's see the next slide. In 2019, we launched the registry, although at that time we still had paper questionnaires, recruited patients at education days, and then sort of called patients back to do this paperwork. Finally, in 2020, the online portal was ready, and this turned into the electronic platform that I just described, and data could be uploaded. And again, patients are still recruited virtual education days, but we've had a great support from AlphaNet coordinators in encouraging people to sign up for our registry and community-wide email blasts that go out. So this is our registry to date. Now, this is, you can see how much better it is when we went to electronic methods. And you can see where we are now. We have 3,311 participants. We are transferring the data, still transferring the data, the original data from MUSC into our registry and comparing patients that are in the registry with that data. But this continues to rise, and this is basically the structure of our database. And the reason I have presented this, although we're in the US, is that that portal where I showed you that we can pull de-identified data, the same thing can happen in the European database, that we can have discussions about patients and important clinical endpoints across our databases by utilizing that system. So that's why we will be collaborating, I would think, Dr. Miravitlles, in many years to come. So I think we're open for questions.
Yes, so if you have any questions, go ahead and put them in the chat. I have one that just came in. Okay, what care are EARCO participants given, and are some alphas given therapy in EARCO countries? And then there's a second part of the question, which is what exclusion criteria is there in severe alpha-1 panniculitis patients directed to augmentation therapy within EARCO countries?
Yep. Well, yes. Obviously, EARCO is a network of researchers and clinicians interested in alpha-1. So basically, the majority of the participants are specialists in alpha-1 in reference centers, and therefore they provide the highest standard of care. And this is also a reason for patients to be included in EARCO, because by being included in EARCO, they will be treated and cared and followed in reference center with the highest level of care, with highest standard of care. And also in the database of EARCO, the CRF includes all the items that should be tested in EARCO in alpha-1 patients regularly as in follow-up visits in the usual checkups. So for this perspective, being included in EARCO is I would say, reassuring that the patients will have the best standard of care. Regarding therapy, yes, but it does not depend on EARCO. It depends on the countries. I mean, there are countries in EARCO in which treatment is reimbursed and countries in which treatment is not reimbursed. So we cannot influence that. So this is outside our possibilities, our scope. In panniculitis, it's not an exclusion criteria. There are no clinical manifestations that are any exclusion criteria. So we include all alpha patients with severe deficiency, irrespective of the clinical manifestations, from completely asymptomatic to lung disease, liver disease, panniculitis, or other combinations or possible diseases being associated or not to alpha-1.
So one question. So what happens with our database is that we reach out. We will send. We can send a blast to the people in the registry if there are trials, if there are surveys, if there are things coming up. How would something like that work with EARCO? Is there a similar process?
Well, we are struggling with data protection, European data protection law, which is very strict. So we are not able to identify patients in the EARCO registry. The only thing we know is how many are they and where they are. But then we can contact the physicians, but we can never go back to the patients. So we have the registry is absolutely anonymized, so we can't contact them. What we can do is to, I mean, in case of clinical trials, we can investigate how many patients may fulfill those criteria, and approximately in which countries and from which centers. And then we can contact directly the investigators, and only the investigators know the patients and the names and the contact details, and they can contact the patients, but not directly from IARCO.